Okay, so this is chapter 13, week 2, lower gastrointestinal system, as I was saying, a continuation to last week, which was the upper gastrointestinal system, which we talked about the esophagus and the stomach and the emptying into the first portion of the small intestine, which is the duodenum. Okay, so now we're going to continue with the small intestine and then going into the large intestine. So the small intestine measures 23 feet in length, uncoiled and stretched out. Okay, 23 feet. That is very, very long. So that is once it is stretched out. And then the length of the small intestine intact without being uncoiled and stretched out is 15 to 18 feet. So make sure when you're answering questions, you're paying attention to the wording. Okay, if it's uncoiled, it's 23 feet. If it's intact, it's 15 to 18 feet. Okay, so the small intestine is centrally located. And then as you can see, the large intestine is going to be in the periphery of the abdomen. So this is what a image of a small bowel series would look like. Okay, so again, this is contrast media inside the patient has ingested it. And so we can see the stomach. Remember, we talked about the air barium distribution levels in the stomach. So I see that there is air in the fundus of the stomach. So that means that our patient is laying prone. So our patient is PA. Okay, so a small bowel series is an exam to examine the small intestine. And it's very commonly followed after an upper GI series. So a lot of the times it's ordered as an upper GI with the small bowel series, or it can be ordered alone as a small bowel series itself. And in the lower GI, we have the barium enema, which is a very not so common exam anymore, but it is to examine the lower gastrointestinal system. So what we're seeing here is air and contrast barium in the colon, okay? So it's important that we're aware of, like I mentioned last week, where our organs lie and in which quadrant they're located in. Okay, so we talked about the stomach. We said that the stomach is in the left upper quadrant. The liver occupies the majority of the right upper quadrant. So the stomach is on the left and it empties over onto the right side into the duodenum. So the duodenum is located in the right upper quadrant and some of the left upper quadrant as well. Goes into the jejunum, which is located in the left upper quadrant, coming down into the left lower, connecting to the ileum in the right lower quadrant, okay, going up into the right upper quadrant as well. So it's very important that you know where these different parts of the small intestine and large intestine are located. So this is a really good slide here. Okay, so you can see the duodenum, okay, which is the shortest part of the small intestine, measures about 10 inches, empties into the jejunum. And so the jejunum has this feathery appearance. Okay, as you can see, it looks different. And then it connects into the ileum. So the ileum is 3/5 of the small intestine. The jejunum is 2/5 of the small intestine. And so what causes this feathery appearance are what are called the plicae circularis. So they're mucosal folds inside of the jejunum, which are going to help with absorption. So that's what's giving this feathery appearance. As you can see here, I like this slide because it can really help you to identify the characteristics of the different parts of the small intestine. So this is a coronal CT of the abdomen. So the jejunum is in this area. The ileum is here. So you see the jejunum looks a lot smoother. The ileum kind of has like a popcorn look to it in comparison to the jejunum. Moving on to the large intestine. So the large intestine is as you can see, on the periphery of the abdomen, with the small intestine located more centrally. So the large intestine is about 5 feet long, okay, and 2.5 inches in diameter. So the colon, okay, which the colon and the large intestine are two different, well, they're separate, okay? So the colon consists of 4 parts: the ascending colon, the transverse colon, the descending colon, and the sigmoid colon, okay? The large intestine also includes the cecum and the rectum. So the cecum and the rectum are not a part of the colon, but the ascending, transverse, descending, and sigmoid colon are a part of the large intestine, okay? So just know the colon has 4 parts: ascending, transverse, descending, sigmoid, okay? But it does not include the cecum and the rectum. That is only a part of the large intestine, okay? So that's important to know. And where does the large intestine begin? It begins on the right side, in the right lower quadrant. Okay, so this is the right side, this is the left side, right? We're always looking at everything in the anatomical position. So we start with the cecum, then ascending colon, okay, all on the right side, transverse colon, and descending colon on the left side. Now, if you notice also, you can see that the ascending and the descending colon are more posterior, and the transverse colon comes forward, more anterior. So the ascending and the descending colon are closer to the spine, and the transverse colon folds anteriorly closer to the surface of the abdomen. So again, that's going to be very important when it comes to the air barium distribution levels, right? So if our patient is supine, the barium is going to go into the ascending and descending colon. Whereas if our patient is lying prone on their tummy, then the barium will go to where? Towards the transverse colon. So the cecum is the widest portion of the large intestine. Okay, it is the first portion of the large intestine as well. It's in the right lower quadrant. And we have what's called the ileocecal valve. Ileo for ileum, which is the last portion of the small intestine, and it's going to empty into the cecum. So the ileocecal valve is a sphincter that's going to prevent contents, which in this case would be barium, from passing too quickly into the cecum, okay? But all contents going through there. So it acts as a sphincter. And then we can see the appendix attached to the cecum. It does become filled with barium, and you're able to see this cute little squiggly line. So this is a lateral view of the rectum. Okay, so this is our sacrum coccyx back here. Anteriorly to that, we have the rectum. Sigmoid colon would be up here. Okay, so the rectum is going to extend from the sigmoid colon to the anus. Okay, so the rectum begins at the level of S3. Remember, the rectum is a part of the large intestine, not the colon. And so this is an image of a barium enema, single contrast, so no air. And we can see the ascending colon, transverse colon, and descending colon. We also have flexures. Okay, so we have a right flexure and a left flexure. They're called the right colic flexure, left colic flexure, or they're going to be called also the right hepatic flexure and the right splenic flexure. Why hepatic? Because this is where the kidney is. Sorry, not the kidney, the liver. Okay, so for hepatic, and then the spleen is on the left side, right above it. So that is for splenic. So they're used interchangeably, so you are responsible for knowing both names. So either right colic, right hepatic flexure, left colic, left splenic flexure. And then here's where you can see that appendix. Let's see here. So we have, very important to remember, along the large intestine, Okay, we have these pouches, right? They're called haustra. The pouches are called haustra, okay? And they're formed by these long bands of muscle called the tennae coli. So this is the tennae coli. It's going to go across all throughout the large intestine. So that's going to create these pouches, kind of like an accordion. Okay. So again, the bands of longitudinal muscle are called the tennae coli, and which are going to help create these pouches, which are called haustra. Okay. So this is the air barium distribution diagram here. Okay, so this is for double contrast if your patient has air and barium. So your patient is supine. Remember, I said that the ascending colon are more posterior to the spine. So barium is white, air is black. So that is why we're seeing barium in the ascending descending colon. This is with our patient prone. As you can see how the transverse colon kind of folds and comes anteriorly and then folds back again. Okay, so patient is prone, laying on their stomach with barium in the transverse colon. And this is just some anatomy. So we know this is the stomach. We have air in the fundus. That means that my patient is PA. A would be the duodenum. G is going to be the jejunum, this feathery appearance. D is the ileum, and then E is pointing to the ileocecal valve, okay, going into the large intestine, which is the cecum. Okay, so this is a small bowel series, which is a timed interval exam. We take images every 15 to 30 minutes. We follow it through until it empties into the large intestine, through the ileocecal valve into the cecum. So this is what we're looking at, the ileocecal valve, which is very important. The radiologists pay close attention to this area. Okay, and then emptying into the cecum. So if E is the ileocecal valve, then D must be the terminal ileum. Okay. A is going to be cecum, B is ascending colon, C is the right colic flexure or hepatic flexure, D is transverse colon, E is left colic flexure or left splenic flexure, F is descending, then we have G would be sigmoid colon, and H would be the rectum. Now, very important to note also how one of the flexures is higher than the other. So the right colic flexure is lower than the left because the liver is pushing it down. Okay, so if you're trying to figure out, you didn't put your marker on the image or on film ID for testing purposes, there might not be a marker. You should be able to identify which side is left and which side is right according to your knowledge of anatomy. Okay, so I know that the left one is higher than the right because of the liver. This is a lateral view. This is H would be the rectum, and then G would be sigmoid colon. Back here we have the sacrum coccyx. Okay, summary of the lower digestive system functions. So in the small intestine, we have digestion, specifically in the duodenum and jejunum. Primarily, we have absorption and reabsorption. And then in the large intestine, we have elimination. Okay, so this is a good little quiz me question. The typical adult's small intestine intact measures how many feet? Very good, 15 to 28 feet. Very good. What is the longest segment of the large intestine? So we know for sure it's not the duodenum. We said that one was the shortest. And then next we said that the jejunum was 2/5 and that the well, that's wrong. And the ileum was 3/5. So I think this one, I'll have to go back and check this one, you guys, because it should be the ileum. Okay. I'm going to go back and double check that. The terms large intestine and colon are synonymous. Is this true? Large intestine and colon are the same thing. False. We already know that they are not, right? The colon is only ascending, transverse, descending colon and sigmoid colon. The large intestine also includes the cecum and the rectum. Very good. Pouches or sacculations found along the mucosal wall of the large intestine are termed what? Those pouches. What did we say those pouches were called? Good. The pouches are called haustra. Remember, the longitudinal muscles that create the haustra are the tennae coli. Okay. In which abdominal quadrant would the sigmoid colon be primarily located? The sigmoid colon. So remember, the sigmoid colon is at the very end. So we know that the large intestine starts on the right side, and if it ends on the left side, so we know it's somewhere on the left. So it is going to be the left lower quadrant. Very good. And the cecum is located in the right lower quadrant. We didn't really talk about this. The transverse colon is an intraperitoneal structure. Okay. Okay, so this is a good one. Which of the large intestine would be barium filled during a double contrast BE with the patient lying prone? So if your patient is lying prone on their stomach, where would the majority of the contrast go? Very good. Yes, very, very good. Transverse and sigmoid colon. Very good. All right, you guys. So there is, so let's go into clinical indications. Very important. You will see questions on clinical indications, contraindications as well. Okay. You will see questions on pathology, and we will go through that in just a second. So let's see, neoplasms, malabsorption, enteritis or gastroenteritis, Meckel's diverticulum. These are all clinical indications for small bowel series. And ileus, okay, is a also known as a bowel obstruction. So what you're looking at here, you see how wide it is. This is actually a bowel obstruction, also known as an ileus. So these are pathologies, and I'm not going to go through each one. I've listed, I have the definition here of what each one is. So I'm not going to read through all of them. I want you guys to review these on your own, because then it would take us a really, really long time. Okay. So definitely go through them, because you will see them on your exam. So I do want you guys to pay attention to the appearance of them radiographically. So for example, Crohn's disease has a cobblestone appearance. Okay. This giardiasis, they're dilated, thick folds, as you can look how weird it looks, right? That because it's dilated and they have very thick mucosa. Again, ileus is an obstruction. Meckel's diverticulum, what you do need to know about this is it's best identified under nuclear medicine. This is a nuclear medicine study, and it's a common birth defect. Okay. All right, so these are the different exams that we're going to be reviewing for small bowel procedures: a small bowel series alone, enteroclysis, and an intubation method. Contraindications. So contraindications to barium sulfate. Okay, pre-surgical patients. So if they're going to go to surgery that day, the next day, within a week or two, you don't want to give your patient barium, because it takes a while to for everything to empty out and be eliminated. Okay, possible perforation. So anytime, so it's important to ask your patient if they've had any surgeries recently. Yes, they had a surgery yesterday or last week or 2 weeks. And you always want to let the radiologist know, and you want them to make the decision. But anytime you have surgery, there's a chance of perforation, right, to your organs. So you don't want to give barium to a patient who has possible perforation. Okay, because barium does not become absorbed by the body like water soluble contrast media. Okay, it becomes like cement. Okay, contraindications to water soluble contrast media would be if your patients have an allergy to iodine. Okay, so this is the very important to know. Okay, so this is for an upper GI, which we covered last week, small bowel series combination. So if you're doing a combination of the both, you're going to start timing it after the first cup given in an upper GI. So it says routine upper GI first, and it says note the time of the first cup that ingested. You want to make sure that you make note of that. Then the patient would ingest the second cup, okay, a total of 16 ounces for everything. And then you take 15 to 30-minute intervals after that. So what you're seeing here, you guys, the radiologist sometimes will spot the ileocecal valve. And so because radiographically, I'm trying to see if there's a nice image here. The intestines kind of are all jumbled up on top of each other. So the radiologist will come in with a compression paddle, or sometimes this, hopefully not, because this is it's very hard and you have to push down on the patient, whereas the paddle is rubber and it's soft. But the equipment does come with this accessory if for whatever reason we do not have a compression paddle. Okay, so this is the routine for a small bowel series only. So just the small bowel series, no combination with the upper GI. So you would take a scout radiograph. So a scout radiograph is an image that you take prior to having your patient ingest any contrast media. So we want to be able to compare it to a before and after, because once you've given your patient barium or contrast, there's no going back. We're unable to compare it to anything else. We might see something here and we want to make sure that it was not there to begin with. It could be calcification. Calcification is also white, right? So we want to always make sure that we have our scout. Then our patient drinks the 16 ounces of barium or water soluble, whatever it is that they're drinking, and you note the time of ingestion, okay? And we would take our 15, it depends on the facility's protocol. Some facilities want you to do a 15, then a 30-minute, or just wait and do the 30-minute, or do an immediate as soon as they drink, then a 15, then a 30-minute, okay? But what you need to know about these timings, what's important is the centering, okay? So everything up to 30 minutes is going to be centered 2 inches above the iliac crest, which we're going to talk about in a second. Everything after 30 minutes is at the level of the iliac crest. So we're going to be taking 30-minute intervals, okay, until the barium reaches the ileocecal valve. So this is an enteroclysis. So this is done where your patient is intubated, okay, with a special enteroclysis catheter. So this patient obviously can't drink the barium or contrast on their own, okay? So the patient is intubated under fluoroscopic control with the special enteroclysis catheter, and the catheter is passed through the stomach into the duodenal junction, okay? And that is where we are going to inject the contrast media. So this is the enteroclysis catheter that you're seeing here, and it goes into the duodenal flexure, which is right here. And then that is when thin barium is injected. Also, air or methyl cellulose. Okay, so this is for the negative contrast media. So either air or methylcellulose is also injected, okay? And then they go to CT. Intubation procedures. So there are two types of intubation procedures. One is therapeutic and the other one is diagnostic. Okay, so that's what you're seeing here, is the catheter in place. Okay, so what you basically need to know about this, the two intubation procedures, you guys, are therapeutic intubation and diagnostic intubation. That's what you need to know from this slide. Okay, patient preparation is very important for all contrast exams, okay? So for the upper GI, we said the NPO was 8 hours NPO, no chewing gum, no smoking, right? It's the same exact prep for the small bowel series, okay? So these are some clinical indications for a barium enema. Okay, so all of the following: so colitis, diverticulosis, neoplasms. So this is what a neoplasm looks like, also known as an apple core or napkin ring lesion, because it looks kind of like an apple core. Okay, a volvulus, which is twisting of the bowel, intussusception, which is telescoping of the bowel, appendicitis. So what you're looking at here is advanced carcinoma of the colon. Ulcerative colitis, again, these are pathologies. I'm not going to go through each one, but you guys do need to review these. Diverticulosis of the large intestine. So it's important that we understand the difference between diverticula and polyps, okay? So diverticulum are they're out pouchings. So they go out, as you can see, okay? Polyps go inward, okay? So in order to view a polyp, you have to do a double contrast study, okay? So double contrast means positive contrast media and negative, which would be air. So in order to see the mucosal lining and to identify polyps, there needs to be air and contrast media, okay? So again, diverticulum go outward and polyps go inward. You see right there, that is a polyp, it's going inward. Again, this is a neoplasm, that napkin core or apple core napkin ring sign. Volvulus. Okay. So the patient prep for a barium enema is a lot more intensive. Okay. So NPO after midnight, so NPO 8 hours, still the same, no chewing gum, no smoking, bowel cleansing cathartics. So they're going to be doing a lot of bowel cleansing cathartics. It comes in the prep kit for the barium enema, and an enema the morning of the exam as well. Why is this? Because we want to make sure that the patient is completely cleared of fecal matter, because we won't be able to obtain a good study if the patient is still full of fecal matter. Fecal matter can also mimic certain pathologies. The two types of cathartics that we're going to use. So again, cathartics are substances that produce frequent soft or liquid bowel movements. So the two types are irritants and saline. Saline is going to be the most common. You do want to know the contraindications to cathartics. So gross bleeding, severe diarrhea, obstruction, or inflammatory lesions. So again, we can do a single contrast barium enema or a double contrast barium enema. So the single contrast barium enema will only use barium or water soluble. The double contrast will use barium and air. Okay. All right. So these are the enema tips. We don't use, he's the one that comes in the bag. We usually just throw these away, because we want to make sure that we have a balloon catheter to hold the tip in place, kind of like an anchor, okay? So this is a rectal retention tip, okay? We want to make sure that It works before we insert it into the patient's rectum because it could be defective, and why the need to do it twice, right? It's very uncomfortable to begin with. So if you see the blue catheter here, you guys, that is for double contrast, because this is the tube that we're going to use to introduce to pump air for the double contrast barium enema. This one is for single contrast. Okay. This is just a little tube that is used to inflate the retention balloon. Okay. Which we have it over here as well. But the one with the blue catheter is to pump air through these holes into the colon as well. Okay. So if we see that there is a blue catheter here attached to this pump, this is what we're going to use to pump air into the colon. Okay, so this is a setup for a double contrast barium enema. So we position our patient into the Sims position, which is a test question for rectal tipping. Okay. So the order would be you go toward the umbilicus first, okay, then slightly anterior, then superior, okay, towards umbilicus, number one, slightly anterior, then superior. So we talked about single contrast, double contrast. So as you can see here, this is single contrast. How do I know this? Because we don't see air. Okay, it's all white, so it's single contrast. Double contrast. So you guys, you see the mucosal lining, the outline of the large intestine. Okay, and you can see the haustra nicely, right? So if we had a polyp, I'd be able to see it in here, versus if it were only single contrast with no air, for example, like in this area, how can I ever see a polyp in here if the barium is going to be superimposing it? Okay, so this is double contrast. Skip over this. So the evacuative proctography, you guys, I want you guys to review it. I'm looking to eventually remove those questions because this is an exam that is not very common anymore, and it's not on the registry. But for testing purposes in this module, you will have a few questions over the evacuative or defecography. Okay, so basically we're injecting contrast into the same thing into the patient's rectum, but we're going to watch them defecate. Okay, so have a bowel movement under fluoro, essentially. Okay. This study is a more specialized procedure that is performed in some departments, especially on children or younger adult patients. So not so much on older adults. Okay, clinical indications: rectocils, okay, and rectal intussusception or prolapse of the rectum. Okay. So you will see a question about this. So you never want to force an enema tip. The height of the enema bag should be no higher than 24 inches above the table. That is a test question. Verify the water temperature of the contrast media and escort patient to the restroom. So verify the water temperature of the contrast media. It should be around, I think there's a question on that, and it is in the book, about 80 to 90 degrees, okay? 75 to 85, somewhere around that range, okay? Okay, so for the small bowel series, you guys, this is important. So for the 15 to 30 minute radiograph, okay, this is for the small bowel, okay, we're going to center 2 inches above the iliac crest, okay? So for 15 minute, 20 minute, 30 minute, anywhere in between, 2 inches above the iliac crest, okay? So 30 minute, 2 inches above the iliac crest. For the hour or anything after 30 minutes, we will be centering at the iliac crest. Okay, so I'm just skipping through that to kind of show you guys. Okay, let me go back. So that's mainly what you need to know for small bowel. It's just a lot of KUBs, essentially, done preferably PA. Okay, so hourly radiographs to the level of the iliac crest. Okay, so as you can see here, you see that there's contrast in the transverse colon. So what is this? What is this telling me? That the small bowel follow through is already done. It's past its time, because when do we cut it off? How do we know that a small bowel series has officially ended? It's when it has reached the ileocecal valve and it's in the ascending colon. Okay, if it's gone already into the transverse colon, then you're way past the time. Okay. Now, this is important to know the technical factors for different studies. Okay, so, and this applies to everything. Okay, so for a single contrast exam, meaning only barium, okay, I'm referring to barium only, 100 to 125 kVp will be your range. Let's say we're doing a double contrast exam, meaning barium and air. So because there's air involved, not just barium, our kVp will be lower, 90 to 100, okay? Now for water soluble, which is a lot thinner than barium, we're going to use 80 to 90 kVp range. Okay, so those are very important ranges to remember. So this is the routine for a barium enema. Okay, we're going to go through each of these. Now, what's important to note, and which can be kind of the harder thing for students to grasp and to remember, okay? So for the obliques, it's going to be important that you know which flexure is being best demonstrated, okay? So remember, hepatic flexure means the right side, splenic is the left flexure, okay? All right, so for the PA or AP, we're going to center at the iliac crest, pretty simple, just like we would for a KUB. Okay, for the RAO, okay, we are going to rotate our patient 35 to 45 degrees. We're going to center at the iliac crest and then 1 inch to the left of the mid-sagittal plane. Now, this is what's important to note, okay? So the RAO, so this is going to be direct relationship. So I would probably remember it through the AOs, anterior obliques first. So the RAO, okay, is going to demonstrate the right colic flexure or the hepatic flexure, okay? So as you can see here, the right hepatic flexure or right colic flexure is open, okay? That's what we mean by what's being best demonstrated. It's in profile. The left one is not, it's superimposed over itself, right? So the RAO will open up the right side, okay? LAO, the LAO, okay, will open up the left colic flexure or the left splenic flexure. So this is the left side, okay? This is the left colic flexure. Now, the posterior obliques are in direct relationship, okay? What does this mean? That the LPO will show me the right colic flexure and the RPO will show me the left colic flexure, okay? So this is an LPO, right? You see she's on her left posterior side. This is an LPO. It's going to demonstrate the right colic flexure. That's why we're centered over to the right side, okay? On this RPO, it's going to best demonstrate the left colic flexure. So indirect relationship, the anterior obliques are direct relationship, okay? So that's what this little chart in the beginning is here for. It summarizes it for you. RAO will demonstrate the hepatic flexure. LAO the splenic flexure, okay? RPO, splenic flexure, and LPO, hepatic flexure, okay? Okay, so here we have both of them side by side. LPO is going to demonstrate the right side. RPO demonstrates the left colic flexure. So essentially, LPO and RAO are the same, right? LPO. Oh, this is really bad. And RAO are going to demonstrate the same side. RAO. This is really bad handwriting. I'm going to stop after this one. You guys get the hang of it. Okay. So then RPO and LAO will demonstrate the same side. Okay. Then we have our lateral, okay, which is to demonstrate the rectum. We're going to center at the level of the ASIS, mid-axillary plane, patient in true lateral position. So the lateral demonstrates the rectum, as we can see here. The ventral decubitus, let me see if we have. So the patient is lying on their tummy and we're shooting it cross table. Okay, so the sacrum coccyx is back here. The table is right here. So your patient is laying on their stomach and we're shooting horizontal, like a cross table. Okay, so we're able to see the rectum. We see air fluid levels. Anytime you see air fluid levels like this, okay, that means that it's a decubitus. Then we have our right lateral and left lateral decubitus, okay? So the decubes are only for double contrast exams, okay? So the right lateral decubitus, that means that your patient is laying on their right side. The left side is the upside. Remember, fluid settles, air rises. Okay, so the right lateral decubitus is going to demonstrate barium in the right colic flexure, as you can see here, and ascending colon, and air, okay, in the descending colon. Okay. If I had no marker here, how would you know that this is the right side, that this is a right lateral decubitus? Because the right flexure is lower than the left, right? And the patient is laying on the right side. Left lateral decubitus, okay? This is the left. How do I know this is the left if I didn't have this marker here? Because the left colic flexure is higher than the right, and this image is showing me that the downside is the left side, okay? So the left lateral decubitus is going to demonstrate, as you can see, barium on the downside, which is the left side, the left flexure and the descending colon. Therefore, there will be air in the ascending colon, which is right there, okay? And then we have our PA post-evac. So we would have our patient go to the restroom and try to eliminate as much as possible, come back and take one more image. And as you can see, it looks deflated. So it's not going to be as full of barium. And you can see that post-evac marker there, giving it away. Then we have our butterfly views, which we call. So the apiaxial, the axial views, apiaxial, PA-axial, and the apiaxial obliques are to demonstrate the sigmoid colon, okay? So for the apiaxial, we're going to angle 30 to 40 degrees cephalic. For the PA, we're going to angle 30 to 40 degrees caudal, okay? And so here we have it. It's going to elongate the sigmoid colon. So it's going to stretch it out, okay? Whereas normally it would just kind of look like that, okay? So for elongation of the recto-sigmoid colon, the AP and PA axial. And then this is a little quiz me, you guys. Regional enteritis, also known as Crohn's disease. Methylcellulose is introduced into the small intestine during the enteroclysis to dilate the loops of small intestine. Okay. Intussusception, and we didn't talk about this, but it is in the book. Intussusception is most common in children younger than 2 years of age. The most common type of colon cancer is adenocarcinoma. Now, this one I do want you guys to try to answer. What is the recommended KV range when a water-soluble contrast agent is used? Only water-soluble. Very, very good. Let me, 80 to 90, 110 to 125 for barium only, right? And then we do the 90 to 100 for double contrast. But for water soluble, it's 80 to 90. Good job, guys. This is, you'll see this question on an exam or assignment. Okay, the IV pole for a barium enema bag is no farther than 24 inches above the table for the beginning of the barium enema procedure. Why is this? Because if it's too high, you guys, gravity is gonna, the speed of the contrast is gonna go a lot faster. It can hurt the patient. And then also we don't want the enema to come out. One of the most common pathologic indications for evacuative proctography is rectocils. Okay, this one I want you guys to answer. Which aspect of the large intestine is best demonstrated with the RAO projection? The RAO. So it's going to be one of the flexures, either the right or the left. Remember, we started with the RAOs because they were the easiest to remember because they are direct relationship. So the RAO will demonstrate the right colic flexure. Very good. LAO will demonstrate the left colic flexure. Which posterior oblique, which PO will also demonstrate the right colic flexure? Do we know? Very good. Excellent. The LPO. LPO, and the RPO would demonstrate the left colic flexure as well. I need to practice this writing. Which of the following projections will best demonstrate the rectum during an air contrast barium enema? The ventral decubitus, the ventral lateral decubitus. If it were asking which of the following projections would best demonstrate the rectum during a single contrast, it would just be a lateral rectum. Okay. What type of CR angle is required for the apiaxial butterfly projection? 30 to 40 cephalic. For the PA, it would be 30 to 40 caudad.